Okay, so welcome to Notes from the Lab, an ongoing series of conversations on the past, present, and future of the BCG vaccine. My name is Denise Faustman, and I'm head of the immunobiology labs here at Mass General Hospital and Harvard Med School. In this podcast series, we're exploring topics related to type 1 diabetes and also the BCG vaccine and also the mechanism of the BCG vaccine. So my guests today are in Germany, and they are Dr. Julia Seyfarth and Wilfred Higgins, who's a graduate student in Dr. Seyfarth's laboratory at the University of Dusseldorf. Dusseldorf, right? Did I say that right?
Yeah,
Ian, okay.
That's right.
You see my last name, and I should be able to speak German, but I can't. Okay. So, and they're from the University of Dusseldorf in Germany, and they're going to give us updates today on their clinical work because they had a very important paper about a year ago on the BCG vaccine and its possible impact on type 1 diabetes. So, welcome to this podcast series. And I'm really happy to have you today to explain some of the thought processes of how you got started on the study. So maybe, is it okay if I call you Julia?
Yes, of course.
Okay, so make sure you call me Denise. So I'd love to learn a little bit more about the overall theme of your lab. And then the next question will be, how'd you start working on BCG? Okay?
Okay, yeah, thank you so much for inviting us. I'm Julia Seyfarth. I'm a pediatrician and senior researcher at the Division of General Pediatrics at the University Hospital Dusseldorf, which is part of the Heinrich Heine University. And our research group is focused on understanding the pathophysiology of type 1 diabetes. And we're, in particular, interested in the interplay between the genetic and environmental factors that then together drive the autoimmune destruction of the pancreatic beta cells. Mm-hmm. So it's not just about diabetes diagnosis and treatment, but we really try to uncover why some individuals, predisposed individuals, developed autoimmune type 1 diabetes and others don't. And we're also interested in how the disease manifests so differently across different populations. Mm-hmm. And here Wilfred may introduce himself.
Yes, thank you again for inviting us. So my name is Wilfred Aniagyei, and my surname is a little bit hard to pronounce, but I'm a PhD student, also working in the lab of Julia at the University of Dusseldorf. So I originally am from Ghana, and I was working at the Kumasi Center for Collaborative Research into Tropical Medicine. And I think that's where we started this collaboration between Germany and Ghana. And then I moved over to Germany to do my PhD. So what I work on basically explores the relationship between the two countries by trying to understand type 1 diabetes in Ghana, which is something we haven't done, building upon the extensive knowledge of type 1 diabetes in Germany that has been ongoing before.
Okay, great. So how did you get started? I mean, we've worked on BCG and type 1 diabetes for quite a while, but what set off the spark to relook at that, especially in populations in Africa?
May you start, Wilfred?
Okay, sure. So I think one of the nice areas is because our group had or started with tuberculosis infused research. So we had quite a lot of experiences with tuberculosis. So I think our experience with BCG stems from there. And then when we transferred this into the field of type 1 diabetes, we quite saw a lot of work from what you guys did with type 1 diabetes and BCG, and looking at this opportunity of trying to understand BCG in type 1 diabetes in Ghana, since we had a national policy where all neonates are vaccinated with BCG, then we could kind of have a direct clinical outlook of BCG in T1D and see what we could see in this untested population as well.
And in your country, when do they give the BCG? Is it at birth, like 3 days after birth? Right afterwards, right?
Yeah.
And which strain of BCG do they use most commonly?
there's a mixture of them. So I think most popular one was the Russian strain of
Uh-huh.
BCG, but there's always a mixture of, I think there's some different batches that you get from WHO, and these are all
Of
given
who
to
can
people.
source at any
Yeah,
given time.
exactly.
Okay.
Yeah.
Yeah, go ahead, Julia.
Yeah, so, and Wilfred already mentioned, but since we know from your studies that the vaccination given to adults had this remarkable effects on the blood glucose, we were interested in whether these vaccinations, which were done in newborns decades before they develop diabetes, might also influence the disease course. And now in Ghana, we have this unique opportunity to have vaccinated and unvaccinated populations. And for that reason, we saw a chance to answer this question.
Mm-hmm. So do you want to tell, and I don't care if it's you, Wilfred, maybe Wilfred, tell us how you designed this study so that people who are watching this podcast understand where the patients came from, how old they were when you started looking at them, and how you got the data from Ghana.
Okay, thank you. So we had like a bigger outlook cohort where we're recruiting from our referral hospital. So when you go to Ghana, in Kumasi, that's like the second biggest city in Ghana. We have one hospital, the Konfanochi Teaching Hospital, that is the referral site for most diabetes patients. So you have people all around this region converging to this one central point for an update or refilling of their insulin. And when there are complicated cases from local hospital, this is where they come to. So we designed our study around this central point, and then we recruited patients and also healthy individuals as well. So what we did in this particular study looking at the BCG is, as Yuria mentioned, split them into 4 cohorts. So in each arm of our type 1 diabetes patients and also our healthy individuals, we have a sub-cohort of those who received the BCG vaccine and those who did not. And then having these 4 clusters, we were able to perform immunophenotyping assays and also measure metabolites to try to understand the relationship between the BCG, type 1 diabetes, and then glycolysis as well.
Which is pretty amazing, because if I were to look at medical records here in the US and say, what childhood vaccines did they have? Unlikely to be in the medical records. Okay. So it's really good record keeping in Ghana to have that information at hand, because in the US, you'd have to go to 3 or 4 separate providers to make sure you got the right information. So there
But
are
actually,
advantages.
it's not. Yeah, sorry, it's not the records that told us about the immunization, but we screened them for the BCG scar. So the BCG scar told us whether they had vaccination as newborn or not.
I see. Okay. So, Julia, why don't you tell us what you found in that study?
Yes, of course.
Monitoring so many people. Yeah.
Yeah. So as Wilfred already mentioned, so we included more than 100 individuals with type 1 diabetes and more than 200 healthy controls. And we then found that, first of all, around 80% of all the people with diabetes and the controls had received the BCG vaccination at birth. So these vaccination rates were similar between the controls and the type 1 diabetes patients. And that basically told us that there's no indication that BCG prevents diabetes from developing. But then it really got interesting, because we then compared the vaccinated diabetes patients and those who weren't vaccinated for several clinical parameters. And what we found was significantly better blood sugar control in the vaccinated group. So we measured the HbA1c levels. These HbA1c tells us about the average blood glucose over about 3 months. And these HbA1c levels were notably lower in the vaccinated group. And we also had a look at another metric that's called IDA1C. So this is insulin dose-adjusted A1C, which combines the insulin requirements and the HbA1c into one measure. And again, we found the same. So the vaccinated patients showed significantly better values. This was really very interesting, and we were, of course, interested in the mechanisms. What could be the reasons for that? And so we did some T-cell phenotyping, because we are also interested always in immune cells. And here we found that the T cells of the vaccinated patients had a significantly higher expression of an activation marker, CD25. So CD25 on CD8 T cells was increased. And here it was compelling that we found a direct correlation between the CD25 expression and the HbA1c levels. So this means that patients with the highest immune cell activation, with the highest CD25 levels, also had the best blood sugar control. Wilfred, would you like to tell us about the metabolic results?
Yes. So what we did then, so as just to pick up from where Julia ended, is that we could at this point already understand the immunological impact in terms of the lowering of the HbA1c and then the immune activation status of their T cells. So we tried to look at metabolic metrics also to try to understand if these vaccinated individuals had a better metabolism state as compared to the unvaccinated. And here what we found was that we saw elevated level of the phosphoenolpyruvate, the PEP, and then the phosphoglycerate. So these are intermediaries of the glycolysis process. And these two metrics were both elevated in the BCG vaccinated patients as compared to the unvaccinated patients. And here we see that this in combination also give us an idea that there may be a role of glycolysis also going underway and higher in the BCG patients as compared to the unvaccinated group as well, which both towards the direction of a cellular shift towards enhanced glycolysis in the BCG vaccinated individuals.
Well, of course, we totally agree with this. Totally agree with this. You know, there's so many studies that are forgotten, and maybe you guys saw this, but in Turkey, they did a similar study where they looked at people who got 0 vaccines, because in Turkey, you can get 0 or you can get 3. And when they looked at the incidence of diabetes and somebody got 0 or 1, they saw no difference. But then with 3 doses of BCG through the age of 3, they started seeing the differences in the incidence as well. But we couldn't agree more. You know, our patient population are these very old adults. You know, they've had type 1 diabetes for 30 years or 20 years, and they have no pancreas function left. I mean, the pancreas is gone no matter how much you stimulate it with glucagon or mixed meal tolerance tests. Their pancreas is gone. And with BCG, their hemoglobin A1C is just beautifully and gradually, it's very, very slow, but gradually comes down from even high levels that would be viewed by most pediatricians, let alone adult endocrinologists, as these are bad. But gradually it comes down. So, you know, what's pretty about your study is the BCG occurred as a neonate. And we think a lot of these off-target effects, especially the glycolysis effect in adults, takes years to really kick in and get the entire lymphoid system sufficiently rewired to use sugar as an energy source. So when you get a vaccine as a child, you don't get diabetes typically till you're 8. So the drug has a long time to rewire the immune system. And in so many trials where people look at the off-target effects of BCG prospectively, they try to run the trial for 1 year. And I keep telling them it's not going to work. It's not going to work. You got to really follow people much longer. So using newborns and having that approximate 8-year window for them to get totally rewired is really a wonderful way to look at this kind of data as you look at it. Did you look at the pancreas of any of these people for C-peptide? I'd predict it could be totally negative, but did you look at the pancreas at all?
So we measured C-peptide in our samples, of course, they had low C-peptide as expected for type 1 diabetes. But we did not see any differences in the vaccination groups. So the C-peptide was similar.
Yes, yeah, because this in our adult population, they're of course pretty much flatlined after 20 years of type 1 diabetes expected, and after multi-dose BCG, they're still flatlined. Okay, they have no C-peptide, but yet these beautiful results in hemoglobin A1C and insulin adjusted hemoglobin A1C, and also in their CGM readings. As a pediatrician, you'd love looking at these CGMs. They're like finally in range, you know, and not just up to 200. We're talking about restoration to normal glycemia, not the pump people here and the CGM people here in the US love using the word time in range. And time in range is really time out of range to 200, the units we use here in the States. But if you look after long-term BCG therapy, they are tightly with restored normal glycemia for the first time, something you cannot achieve with insulin. So you have to go back and get all those other kids vaccinated at birth to protect them. Do you want to talk a little bit more about what aerobic glycolysis is for the audience, of how it works and how it works in lymphoid cells for energy metabolism?
Yeah, of course. Let me explain it in really simple terms. So when the cells need energy, they break down glucose, the sugar in the blood, and there are two main ways to do this. So the first way is oxidative phosphorylation, which happens in the mitochondria, which is the powerhouse of the cell. And this process is very efficient. So produces 26 to 28 ATP molecules, which is the cell's energy currency from each glucose molecule. And there's another way that is glycolysis. And this happens in the cell's main compartment, in the cytoplasm, and not in the mitochondria. And in this aerobic glycolysis, the cells break down the glucose and they produce only very few, so only 2 ATP molecules. So this is really much less efficient. But what's special about that is, although it's less efficient, it actually produces the ATP much faster. And it's about 10 to 100 times faster than oxidative phosphorylation. And this means that the cells can consume much more glucose during this aerobic glycolysis. And for that reason, the cells switch to this metabolism primarily under conditions where rapid ATP production is required, and even if oxygen is present. And this is has been described initially for cancer cells.
Yes, the Warburg effect, right?
The Warburg effect, and they use this aerobic glycolysis to rapidly build blocks for growth. And but we also know it from normal cells that they can switch. And it's mainly activated immune cells that also use this strategy when they really need to proliferate quickly.
Mm-hmm. Mm-hmm. It's an interesting thing. Somebody once explained it to me as if you're a cell and you have a really important job assignment to do, you can't turn on 20, 30 genes in the OXPHOS pathway and have any ability to do another function. So aerobic glycolysis allows you to do the job assignment at hand with a little inefficiency, but you're turning on so few genes, it uses less manpower overall for the cell. So it's certainly relevant to cancer, and I think now really relevant to diabetes as well. So we were very excited to see your study. So now that you got this data, what's your next study? Because Wilfred, you got to have a thing called a thesis when you get done, and
Yes.
it's got to go before a committee. So what do you? I'm not prying for anything proprietary, but what are you think the big topics you need to work on so you actually get your PhD? And I can call you Dr. Wilfred Higgins.
Yeah. So for BCG work itself, so for my PhD, as you asked, this was like the first study to try to explore the area and try to understand how the BCG impacts the type 1 diabetes in the context of our neonatal vaccination, which is a program that has been going on for many years. And what we see from here also opens more doors and asks more questions. And what we plan to do then is to zoom in closer to try to understand the context of the BCG in type 1 diabetes and also in other forms of diabetes that we have seen in our Ghanaian cohort. So as you mentioned, we recently also came up with another study to explore the heterogeneity of diabetes in sub-Saharan Africa. And we've seen the presence of atypical diabetes forms. And it's also interesting to look at how BCG plays a role in these other forms as well.
Mm-hmm. It's such an interesting old-fashioned drug to have these amazing off-target effects. And have you guys also been tracking, and this is really a pediatrician question, infectious diseases? You know, the other off-target effect of BCG is platform protection from infectious diseases. Have you had the opportunity, or do you have the means to look for the vaccinated, unvaccinated kids for protection from infectious diseases?
So in our study, we also collected data about worm infections of our patients. So we screened the urine and we screened the stool, but the proportions were not high enough to assess whether BCG has an impact on that as well. So as said, so we have less than 20% of patients that did not receive the BCG vaccine, and this, of course, makes this group quite small.
Okay, yeah. In our hands in adults, the infectious disease protection takes sometimes 7 years in adult vaccines. So it's a much slower process than the change in aerobic glycolysis or the change in hemoglobin A1C. So the kinetics, and this could again be, Julia, related to the power of the study of the incidence of infectious diseases versus us recruiting everybody that has a high blood sugar. So it's certainly in COVID here in the US, we could pick up really nice signals. But then the incidence of infectious disease was very, very high. So the infectious disease studies that we try to do in parallel are much harder to do. It's slower in adults kicking in. And also, you almost need a pandemic to get the numbers high enough to get enough cumulative events. So
but what we know from other studies is that BCG vaccination itself has a great impact on childhood mortality.
Oh, so absolutely. Absolutely, yeah.
The impact of BCG is really enormous. So.
It's huge, especially, I'm sure you know Christine then, and her studies of childhood mortality. This is in Guinea-Bissau, a different African country, but very, very low birth weight. They showed that the low birth weight infants that didn't get BCG had like 70% higher mortality within 1 year. And that was from infectious diseases. So I mean, in the US here, can we ever get this vaccine given at birth? I don't know. But instead of withholding it from preemies or withholding it from sick newborns, maybe they're the ones that actually need it in order to have this secondary protection, let alone protection 8 years down the line from diabetes itself, which is just amazing to I always laugh a little bit. The whole diabetes world has been going for 20 years with more and more immunosuppression and earlier and earlier unaffected children. And we've always been going in the opposite direction of what can we do for adults that already have the disease instead of just giving them another pump, another CGM, another form of insulin. So changing metabolism seems to be a fashionable and very effective way to get better control than insulin. So we encourage you guys to pursue it. And if you need any help, just let us know. And it's hard for PhD work because if you're doing new vaccines, it takes a while for the full effect to kick in to become systemic, but it's very powerful once it kicks in. So I hope you guys keep working on it. And in the US, there's always a little flack about working on something so simple and so easy. But it's so elegant. The mechanism of it underneath is so elegant and not immunosuppression.
Yeah, and as Wilfred already mentioned, so we are interested in whether this newborn vaccination doesn't only has an impact on type 1 diabetes, but also on those other atypical forms of diabetes that occur in Ghana. And yeah, we just recently published this study where we found this huge heterogeneity in C-peptide levels in patients diagnosed with type 1 diabetes in Ghana. So only less than 30% actually had the classical type 1 diabetes profile, although they were diagnosed with type 1 diabetes, and all of them were persistently on insulin. And so we believe that these up to 70% of patients with this surprisingly high C-peptide is suffering from an atypical diabetes form, like, for example, ketosis-prone diabetes. Because these patients, many of them presented with ketosis, with ketoacidosis at onset of disease. And we are now in particular interested whether BCG vaccination may also affect the disease course of those patients with atypical diabetes.
And it could be other infectious diseases they have in guana, or plus or minus the BCG vaccine that causes the atypia. We're also working a little bit with LATA cohorts, and I use the term LATA meaning they're in the US. They've never had BCG, of course, but they, quote, get type 1 diabetes when they're 30, 40 years old. And they have autoantibodies, and the C-peptide declines over 10, 15 years. Very, very slow, very indolent. So we're looking at that type of atypical diabetes as well to understand their response to BCG. And they're kind of interesting because they have a pancreas that's decaying so slowly, but they do not have the aerobic glycolysis defects. They do not. So we're studying as well BCG in those cohorts to understand its pure effects on pancreas decay through the Treg mechanism without the aerobic glycolysis contribution. we're also doing a lot of trials in kids too. And so they'll have both, right? They'll have the aerobic glycolysis defect, and they'll also have a rapidly disappearing pancreas. But you guys started out at birth. I started out with the old people. But at some point, you have to converge and put it all together. So I wish you guys the very best in these studies. Certainly a little disruptive, but I think when you look at the clinical trial data, it's irrefutable on the benefits of something so old, reintroducing it, at least in the US and maybe in Europe. Yeah, when did Germany, did they stop giving the BCG vaccine? They gave it years ago.
Yeah, that's decades ago that they stopped. And in Germany, actually, or in one of the German studies, they also tried to find out whether BCG vaccination was associated with the development of type 1 diabetes, and they did not find any association. So as we also saw, no differences in the vaccination proportions.
And that should have been, we got involved in BCG, not because we're infectious disease people, but we had been mapping lymphoid defects in diabetics and realized there was an alteration in the TNF pathway. So we wanted a drug that induced TNF. And it was either produce a new drug, or use something old like BCG that's known to induce cachexin or what later became TNF. But when we started those studies, there were actually 3 clinical trials, trying everything in new onset diabetics. There was one in Israel that kind of suggested maybe, new onsets that had something, but it was open label. And Kevin Lafferty was one of the authors on that. And they said, yes, they got it. And then there was the European studies and the Canadian studies with US recruits. They gave one vaccine and looked in a year and they said it doesn't work. Well, we now know one vaccine for delaying the onset or prevention doesn't work. It's just not enough, whether it's our work, their work, or the turkey work. And you have to give multiple vaccines and you have to wait like 5 years, especially in the older populations. So it's all like pharmacology 101, it's not as easy as just pop in and give one vaccine. That's why the newborns are so fascinating, because by the time they get diabetes, there's been plenty of time for the distribution of this vaccine to every lymphoid cell that's there. So, well, go ahead.
Yeah, but so it's much more than incidence, of course. So the practical implications are profound. So we really need to better understand the mechanisms to be able to mimic this BCG's beneficial effects. And so it would be of great interest to identify patients that could benefit most from booster vaccinations or also from metabolic therapies that try to enhance this aerobic glycolysis. So the field is really huge.
Yeah, absolutely. And metabolism, when I learned about metabolism, Wilfred, it was like, this is type 2 diabetes. Hardly anybody uses the word metabolism in type 1, but what are we talking about? We're talking about metabolism in type 1. That was really missed for decades. So I agree. People who have this vaccine as adults have such refined blood sugar control. Most adults are just on basal insulin. They no longer have to bolus. And as time goes on, like about year 8, they have normal hemoglobin A1Cs. They're in the normal range. So you give it enough time, you see this amazing blood sugar control. Okay. Thank you, Julia and Wilfred, for joining us today and the many contributions you've made already to BCG research, especially in type 1 diabetes, a favorite topic. For all our listeners interested in learning more about this podcast series and our BCG clinical trials at MGH, please go to www.faustmanlab.org, and we try to post papers that are on this topic. And if you have a new paper, send us the new paper and we'll try to post it as well. So good luck on your studies, and Wilfred, good luck on your thesis. It's a lot of work, but you're working on a great topic. Okay.
Thank you. Thank
Yeah.
you for having us.
Thank you
Okay.
for having us.
Yes, yes. Okay, Russell, we're going to say bye.
You're all set.
Okay.
Bye.
Okay. Thank you so much,
Bye.
guys. Okay.
Bye.
Bye.